Hello, ethics. I'm on a video roll today, and it's Friday and it's raining, but it's kind of nice and cool. The fall weather is finally starting to kick in. I hope everyone else is having a good day. This is Pato. He says hello. He's getting pets right now, so he's purring. Okay, well, today we're going to talk about Chapter 10. So ethical issues with your counseling practice related to theory and techniques and evidence-based practices. So I'm going to go ahead and share my screen. And slideshow. All right. So the first thing we're going to talk about is theory and how that relates to ethics. As you know, it is important to use evidence-based practices, and you should choose a theory that resonates with the research. All the theories that you'll learn in this program are based in research or have been well established in the field. So if you pick a theory that's taught here at MSU, you should be okay. And so you want it to resonate with the research, but also even more than that, you want to find a theory that works with your personality and your beliefs about life, psychotherapy, and human healing. So each theory has a theory of personality development and an approach to solving problems and beliefs about humans and how they interact with the world. And so you want to really do your homework, do your searching and your research, and find one that really works with you, because if you're being authentic in who you are and how you treat problems, that'll come across effectively in your work with clients. Not every theory works for every client. And so sometimes we have to adapt or even change our theory to work with a certain group of people. For instance, an existential approach, which is very philosophical and based on four givens of existence and searching for deeper meaning in life, is not going to work for, say, a child who's not really at a developmental level to understand purpose and meaning and seeking out, those things that make us whole. So you may want to use a different approach, maybe child-centered approach, or reality therapy or cognitive behavioral therapy, something that is a little easier to grasp at any developmental level. So you just want to be mindful of that when you're working with particular groups of people, that not every theoretical approach is going to work with every client. That being said, you can still utilize your theory in terms of conceptualization, but you may need to use techniques from other theories to address certain issues or help particular people with different things. And so we just adapt and we learn and we read and we find what works for that client. You can use, like I said, techniques from other theory that work with a specific population. I know that I have a specific theory, but I also pull techniques from like cognitive behavioral therapy, reality therapy, from a variety of different places. And of course, we want to keep learning. We can, there are emerging theories all the time, and then specific ways to approach different issues like trauma-informed care. Having a deep understanding of trauma can help us work with probably all clients, because almost everyone has experienced some sort of traumatic event. Maybe not everyone, but a lot of people have experienced traumatic events in their lives. So having an understanding of trauma-informed care could influence your theoretical orientation, or it can be added as another layer. If you think about like having a tool belt full of all these tools and skills that you can pull out at any given moment, it's always good to have a variety of things to pull from. Motivational interviewing, that's really specific to substance abuse, but could be used in a variety of settings. And then there's cultural relational theory, which is basically the multicultural theory, and it really focuses on an external environmental conceptualization of the client. So Some theories are rooted in individualism and Western views of what makes a person whole. And this one kind of takes into consideration all of the external environmental factors that come together to impact an individual. And ACT, acceptance commitment therapy, is kind of a blend between mindfulness techniques, Buddhism, and cognitive behavioral therapy. So there are all different types of approaches. And feel free to pull from those different approaches as you learn about them. And just as I was talking before, not every theory fits every client. And so we want to be considerate of culture when we're conceptualizing and setting goals. As I mentioned before, so theories are based in worldviews, assumptions, and culture. And most of these, historically derive from Western male and middle class approaches. And that's just sort of how psychotherapy emerged. Psychotherapy started in about 1900 by Sigmund Freud, who was, of course, an Austrian Western European male. And his theory is also rooted in the cultural constructs and paradigms of the time. So, it is largely based on a male perspective, a Western perspective, which is individualistic and capitalistic. So we need to consider that when we're looking into the different types of therapeutic approaches that we would like to choose. As I mentioned before, there's relational cultural theory, there's a systems approach. There are some different types of theories that have emerged more recently that are a little more broad. There's also, Asian theories and approaches, Eastern approaches that can be combined or used in lieu of the Western approach. So it's just important to understand. That's why I say do your homework, because it's really important to understand where your theories are coming from. And you can choose to accept or reject some of the concepts of the theory. So, or just adapt and focus on the client needs, the client goals, and what it means to be whole and human and well from the perspective of the client. So someone from a communal culture may not value the same things that someone from a Western culture will value. And so we just want to make sure that we're considering that when we're treating clients. And, of course, theories can be adapted for working with various cultures. It provides a framework or structure for working with clients. And so having a theory is very important. But no theory will have a set of steps or something that works every single time. And it's always good to kind of go in with a plan, but know that the plan will change the minute the client walks in the room, because maybe we have an agenda or we want to expand on a goal that we were working on last week, and they come in with a crisis or something different, or thoughts that they had that kind of changed the course of therapy, and we have to be open to that too. So and when we're discussing the division of responsibility in counseling, we touched on this a little bit with informed consent. But of course, the informed consent document and verbal informed consent in the therapy process is a great way to set up the counseling relationship, to set expectations for who's responsible, and to help the client understand that it is a shared responsibility between the counselor and client. We want to be careful not to make any guarantees that a certain approach will work or that your time with the client will be 100% effective. And you want to discuss and outline in conformed consent factors like participation, honesty, putting in the work, and a fit between counselor and client can all impact the effectiveness of treatment. Also, medical issues can impact treatment, and major life events that happen during the therapy process can impact the effectiveness of the counseling relationship. So we want to be transparent about our goals in the counseling relationship with our clients, and we want to give them as much autonomy to choose their goals and their desired treatment outcomes as possible. And we're going to share with them the length and amount of sessions. Insurance can affect this, or the type of program. So if you're in private practice and you're not accepting insurance, that's totally up to you and the client, right? But if you are in an inpatient program that is funded by a grant, maybe the grant provides 12 sessions only. So you would want to outline that with your client. Also, their insurance benefits will dictate how long therapy might last. But you want to spell that all out with them. And then diagnosis. So there's a responsibility to diagnose, particularly if you are receiving reimbursement by third parties like insurance companies. And so it's important to just let them know what the role of diagnosis is in the counseling relationship. Again, if you're in private practice and you don't accept insurance, you may choose to not diagnose at all. But we do have ethical responsibilities around that. So we need to ask ourselves, and we'll go in a little later on the pros and cons of diagnosis, but I do want to just point out that we need to really consider our ethics in terms of, if we choose not to diagnose a person, will that keep them from getting treatment they need, or will it protect them from stigma associated with that diagnosis? And then we want to talk about our approach to counseling, our theoretical orientation, the length of sessions, and what all of that will look like. Goals. The goals of counseling should be co-created and agreed upon by all, because it's unethical to push our own agenda or our values on a client, as we've mentioned before. Really, they're there to seek out their best life and their version of health and happiness and wellness. So our goal is just to help them get there, whatever that means to them. If their version of happiness is devoting their life to, Burning Man and other festivals, then that's what we need to help them do. If their best life involves having a family, maybe we can help them work toward that goal. If their best life means, being the best at a sport, whatever it is to them, we need to respect that and try to understand their version of health and happiness and wellness. And of course, again, the aims of therapy and goals of therapy should be specific to a particular culture's definition of psychological health, if they adhere to their cultural heritage and the culture of which they're a part. And no single approach is equally effective in working with all client populations. So the research shows that counseling works. There has been more research done on some types of therapy over others, but what they have found across the board is, regardless of the theoretical approach, that counseling still works. So it really does come down to the relationship. So goals in specific situations, we have an ethical responsibility to create in effective ways. So in terms of crisis, you want those goals to be specific and aimed at keeping the client safe and managing the situation until the crisis is resolved. So this is kind of like the Band-Aid approach, making sure there's a safety plan in place, having people they can call, having a plan for when they start to feel that way, so that there are very just specific steps they can take to keep themselves safe and protected until they can get stable. And then in managed care, so this might be in a inpatient treatment facility or even an outpatient facility that's highly regulated. The goals need to be specific, coping skills focused and short term, and maybe much more directive and diagnosis focused. And mainly this is because of the structure of pay. There's just very limited time for the client to be there. So they have to maximize the amount of time they're there by, safety planning, focusing on coping skills, and coming up with plans to kind of get life back on track. And then in schools, you're going to mix educational goals with social and interpersonal goals. And then in older adults in assisted living, it might be related to coping skills regarding socializing with others. It could be more of a reflective meaning-making approach to looking back on life and making the most of what is now, but also reflecting on one's life from a developmental lifespan perspective. And as far as techniques in counseling go, we need to execute techniques in ethical ways. So they need to be purposeful. They need to be rooted in evidence. And you need to ask yourself, why are you choosing a certain technique? Is it connected to an objective, which then leads to a goal? That should be the appropriate way to use it. And yeah, so in terms of being purposeful in choosing techniques, you want to choose a technique that really does lead to helping with a goal. I sometimes see newer counselors throwing out a technique as far as like trying to just give advice to someone, okay, let's try this, but they don't really know why they're trying it. And it's almost like they just need to feel competent, or they don't know what to say. And so they throw something out, but really there needs to be a purpose behind it. There needs to be an intention, and it needs to be kind of goal driven. And then finally, technique without relationship is pointless. So I want to point that out, because you can have clients do as many worksheets as you want. You can have them do technique after technique. You can teach them coping skill after coping skill. But if you don't have a relationship with that person, it's not really going to stick. The person has to trust you. It really is a relationship. And within that relationship, you can do great things. But without the relationship, none of it really matters. And let's talk diagnosis. So diagnosis is used to help shape goals and treatment plans. It helps client with a deeper understanding of what happens to them, and it can take away blame. So they feel like, oh my gosh, I finally know what's going on with me. I felt like something wasn't right for all this time, and I just thought it was me that was the problem, or that I was just broken, and so it makes them feel less alone, and it gives them hope, because if you know you have a specific diagnosis, okay, well, there are treatments that you can engage in to get better. Diagnosis is also, as mentioned previously, required by insurance companies for reimbursement. And it's also really important for treatment planning, because it helps shape goals. And there are evidence-based practices and research for specific diagnoses you can seek out to help you treat that person. And it also makes planning on a team a lot easier, because everyone has an understanding of the diagnosis, which then helps them shape their interventions accordingly. So if you are working, with other therapists, or in a treatment facility where different people have different roles, but they're working with some same clients, then that makes it easier. And it also helps counselors rule out other medical conditions. And the DSM-5 is what we use to treat clients. It's the Statistical Manual of Psychological Disorders, and it's put out by the APA, and the most recent edition came out in 2013. And some of you may have already taken diagnosis class or are in my diagnosis class currently, so you guys definitely better know all about the DSM. But for those of you who don't, you will get that later in your program. You'll learn. Arguments for diagnosis. So these are some reasons why. So we mentioned it before. It helps to assess risk for harming self or others. So if you look in the DSM, you can look at at the percentages of people who have that disorder, prognosis for that disorder, and risk factors are even included in the DSM. So if people are at higher risk for hurting, attempting to harm themselves or others, that's listed in there. And so that can help. It's also the minimal standard of care for some counselors. So being able to just diagnose what's going on and starting from there and shaping goals around that. It provides a framework or a starting point for evidence-based treatment. It helps client normalize situations. They feel less alone. This is something that happened to me. I didn't cause this. I have this disease, not I've made horrible decisions throughout my life that have just ruined my life. So there's a reason for maybe why things have been more challenging for that person. And again, third-party reimbursement, and it's also critical to determine success in counseling. So if you have a particular diagnosis and you're using goals and treatment plans surrounding that diagnosis, then you have kind of a baseline to look back on and get that, like, knowing how or when to get that person back to normal. Or if they do, then you kind of know based on the criteria. Okay, and then there are mental health professionals who don't believe in diagnosis. So, the idea behind, and there are some very legitimate reasons why people don't believe in diagnosis, and they believe that the DSM is emphasizes pathology, which is true. It's a little different from our profession, because in the counseling world, we focus on wellness and wholeness, and we're not necessarily approaching it from a medical disease model. But the APA and the DSM, in the DSM, it very much is, it's called the Manual of Disorders. So we are looking at it from a bit of a deficit model. And it can minimize the uniqueness of the client. So, oh my gosh, yes, I do agree with this, that, bipolar 1 is going to look different in different people. ADD or ADHD will look different in different people. So there's really not a one-size-fits-all model. And the DSM diagnosis process can be a little reductive in the sense that you're saying, well, it literally is, does this person hit 5 out of 9 criteria? Okay, what if they hit 4? What if they hit 3 most of the time, but sometimes they hit 5? So, a lot of these things happen on a continuum, and it's not a perfect science, to say the least. It ignores the natural capacities for self-healing. And the truth is that sometimes just starting counseling can propel the client into a pattern that is more positive for them, that helps them get well. And people do have the capacity to heal themselves, to work on things, or to manage and cope with maybe some existing mental illnesses that they have. The idea that some people really don't like the idea of diagnosing, because it can lead people to self-fulfilling prophecies. So, well, I'm ADD, so I just can't do that. Or, I don't think I can achieve at a level that my peers can, so I'm done trying. Or I'm just depressed and this is how I'm always going to be. Or, I have anxiety, so I'm just going to keep avoiding situations that make me uncomfortable. Well, we know that, for anxious people, avoidance is actually the worst thing that they could do. And treatment focuses on not avoiding those situations, jumping in, working on perfectionism, etc. It's kind of like the difference between a fixed mindset and a growth mindset. And so some clinicians fear that with diagnosis, people fall into the fixed mindset or use a lot of excuses. It also assumes that distress in the family is a result of individual pathology. And so if you look at a lot of different theories like systems theory and relational cultural theory, again, and in feminist theory, they all look at the external world as being problematic, whereas the DSM is very individually focused, which fails to take into account poverty, external circumstances, traumas that someone's experienced early in life, and how those might impact someone's development. And instead, you're just saying, oh, well, they're ODD, right? So if someone acts out their ODD, but it does not take into account all those other environmental factors that may be impacting the person. So as counselors, we need to make sure we do look at those environmental factors. The other ethical issue with diagnosis is that many therapists are not competent to use the DSM properly. So, obviously my goal in the class is to teach you all how to use the DSM and teach you enough about the disorders so that you have a working knowledge enough to know, okay, well, that seems like generalized anxiety disorder. I'm going to open up my book and see. And if not, you're going to look at other, you find it in the same chapter, there's a lot of differential diagnosis, but you have to know enough about all the disorders to know what it could possibly be other than what you think it might be if they don't fit the criteria. And so, of course, people diagnosing incorrectly or if they're just kind of giving blanket general diagnoses that kind of fit but aren't totally correct, that's unethical because the person's not getting the type of care that they need, and they're not getting the correct diagnosis. They may even have an inaccurate view of what's going on with them. So it's really important that we work hard to get the correct diagnosis, and that means we need to educate ourselves on how to use the DSM and how to diagnose. And the DSM itself has been criticized. So the reliability and validity has been questioned, and the failure to predict treatment outcomes is criticized. Also, the DSM has had, I think, five iterations. We're on the fifth one now. And it is culturally bound and based. And so this is an issue for everything. In the 1950s, the version of the DSM that was popular, looked at same-sex partnerships as a disorder. Of course, we've changed our thinking on that a lot by the time we've gotten to 2018. But the same thing, people criticize it because it fails to take into consideration cultures, normalcy in different cultures. And there are some criticisms about certain diagnoses as being prejudiced or biased towards certain types of people. Like borderline personality disorder is typically been a female-oriented disease, so it's often overlooked in males. So there are a lot of problems then with the DSM itself as well. So those are things that you want to keep in consideration when you're working with clients. It's also important to let clients know that just because you have this diagnosis does not mean that it defines you. It doesn't mean that it's going to shape your life in one way or another very drastically if you don't make changes. Just having the diagnosis doesn't really do anything except it kind of starting point. And, it's important to impress on clients that there is stigma associated with some of these diagnoses. And so you may want to be careful about how and when you share that information. It's also important to think about how and when to share that information with clients. So it's just something to think about. Lots of things to think about. All right, ethical and legal issues in diagnosis. So medical evaluation is always recommended and often required for accuracy. We are not medical doctors, so obviously we cannot recommend medication or diagnose someone with some sort of medical issue. We need to refer them to their doctor as part of our intake process, really. Because if there is something, we need to understand holistically what's going on. And if there is something medical, that could really impact their ability to address their mental health issue as well. Competence in using the DSM appropriately is an ethical issue, and we talked about that on the previous slide. And then we've talked a lot about culture and how that can impact a diagnosis, because what's normal in one culture is different in another. Cultural sensitivity is essential. There's a tendency for some practitioners to overdiagnose, underdiagnose, or misdiagnose clients from marginalized groups. As we mentioned before, someone may be presenting and it looks like ODD or oppositional defiant disorder, but maybe that's rooted in trauma. Or maybe, they're stealing, which looks like an antisocial behavior, but they're in poverty. And so that's really just a survival skill. So we have to really look holistically at the client, the culture, and their environment. We need to accurately assess and diagnose, and that involves taking into consideration the realities of discrimination, oppression, and racism in society, and mental health disciplines. So we've come a long way cross-culturally. The 1960s is kind of when this multicultural approach started to infiltrate mental health treatment fields, with the women's movement, the civil rights movement, all these different things. But then there was some really harsh criticism of approaches to psychotherapy that did not take into consideration the perspectives of women, people of color, minorities, people of different socioeconomic groups. All of the research was basically based on white Western males, again. So there's a lot of criticism there. And so some of these diagnoses are still rooted in that mindset, which means that we can misdiagnose people, or underdiagnose or overdiagnose, because we're not seeing the entire cultural picture. So we need to be aware of that. We also need to be aware of ethical issues related to testing in counseling. So we need to be familiar with tests being used and take tests themselves, recognize limits of competence to use and interpret tests. We need to know the reasons why a particular test is being used and make clients aware that tests are merely tools that can provide useful information, but that they're not the be-all and end-all. It's important for counselors to select tests that are appropriate for clients, given their unique cultural, social, and cognitive factors, which can be challenging if there's not a test that's been normed on a certain population. It's unethical for us to really give that because it won't be reliable or valid. We need to give test results and not simply test scores. So we need to explain and interpret results. That's part of our ethical duty. We need to be sensitive to the ways clients respond to results and be supportive and be there for them. We need to assure clients that test results will not be used against them, that we're there to protect them and help them. We need to assure confidentiality unless consent is given, and we need to know the limitations of tests being used. Evidence-based practice. So I've harped on this before. We need to be using evidence-based practices, which means that we're using the best and newest information. We're continuing our education. We're studying, we're reading, we're finding the newest ways to treat and approach clients. And we need to consider our own training before we implement these evidence-based practices. So just because we learned about a new technique doesn't mean we're trained in it or we know how to use it. And we need to think about the specific client before we just jump in and use it, because not every client responds to every technique. So what does the research say about counseling in general? It says that therapy works. We know that, which is awesome. And it's exciting for all of you going into this field because you know that you're going to be doing something to help other people. So some people make changes pretty early in the process. Is that because there's a placebo effect of just choosing to make the change? And in general, most theories achieve similar outcomes. So as long as you pick a theory that works for you, that is, rooted in history and evidence-based practices, you're going to be fine, because the most important thing really is the relationship. And then that's the best predictor of the outcome. So your relationship means more than your theory, more than everything. And most therapists learn effective techniques through practice and experience more than research. And 10% of clients do get worse. Some of the reasons for this might be that it is that idea of it gets worse before it gets better. It's very, very difficult to talk about things that are painful, and it may bring up and re-trigger all the issues that maybe happened in their life. And it may be that they don't have the coping skills. So we really need to work on our relationships with clients. We need to make sure that they're ready and that they have the coping skills they need before we pull out their deepest, darkest traumas. We want to work gradually to a place where they're comfortable sharing these things and working through them. And that is all I have for you today. I hope you have learned something about theory, evidence-based practices, cultural considerations for diagnosis, ethical issues surrounding diagnosis and testing, and then the most important thing, which is that no matter which approaches you do choose, that everything comes down to the relationship. So I hope you have a great day and you're enjoying the fall weather, and I'll see you next time. Have a good one.